Welcome to the Plastic Fantastic podcast, brought to you by breast and cosmetic surgeon Mr. Adrian Richards and myself, Alison Telfer, a nurse specialist in all things non-surgical. Each week we will be bringing to you a different guest to talk about anything that's in or around either plastic surgery or the non-surgical environment. We hope you enjoy the show.
So we're delighted today to be introducing Bill Townley to you all. We're delighted, aren't we, Al?
We are really delighted, and I guess for those of you who know Bill Townley is also known as William Townley professionally, which I've just learned, and a fantastic plastic surgeon. So we're going to sort of go through that journey with him.
Yes, so Bill,
thank you very much for having me.
So Bill, to tell us first of all, where are you now?
Okay, I'm right now, I'm actually in the Shard. On the 4th floor, not the 90th floor, but this is where I do my private clinic every Friday. And that's where I'm reporting from right now.
And it's really near Guy's, isn't it? So you work at Guy's and Thomas's.
Yeah, you can actually, the windows are down, but you can get a sense of where Guy's is. It's literally right next door, so it couldn't be more convenient. Yeah, we're right, the building next door to the Shard, so it works really well.
I was going to say that makes the commute quite easy then, doesn't it, between the two?
Yeah, between the two, it makes it extremely easy, and being able to sort of, move between the two is very convenient.
And remind me how many floors there are in the Shard, because people may be not familiar with the Shard listening.
Yeah, I think it's the tallest building in Europe. I have been up to the top, but it's around 80 or 90 floors. The Shard outpatients doesn't extend beyond the 6th floor, however, so there's no privileged view from here, but it's great being in a building of such massive importance in London.
Yeah, it's got a lovely hotel at the top, hasn't it, Alison?
Yes, it has, and a great cocktail bar, which is obviously important.
I believe so.
Yeah.
Now,
a few of them actually.
I want to go back a little bit. I want to find out,
sure.
And everyone wants to find out, is how we got to the Shard, or how you got to the Shard, essentially. So you've got a bit of you started life in London, but there is a dual citizenship. Is that right? Talk me through that a little bit.
Yeah, that's right. My mum's Canadian. In fact, I was born in Toronto and lived there for 8 years before moving to London. And then basically I've been in London ever since. In fact, I often get told I have a bit of an accent, and no one can quite put a place on it. A lot of people think I'm South African, which is slightly upsetting, but I do have a bit of an accent, but I spent 8 years in Toronto, and then I've been in London ever since. So my dad's English and my mum's Canadian, but my life, even from moving to London, I think I've bounced around between the two quite a lot, and they're both important.
Yeah, I saw that. There is something interesting, I can't remember, and this is why you still hold some part of the accent. There's something about if a child stays in a certain country and their formative years until a certain age, I think it's something like 9, then they will hold on to some of that accent, even though they've sort of left years ago.
You haven't held on to your Australian accent, have you?
Well,
no, I haven't.
Oh, that's true. You grew up in. I'll tell you something interesting, which people can never quite understand. My brother is 2 years older than me, so and this may actually completely prove your point. He was 10 when we moved to London, and he sounds 100% Canadian.
Yeah,
but he lives in London.
But he lives in Canada now. But even before he moved back,
that might be why.
Even before he moved back, he sounded Canadian.
Okay, brilliant. So, how did you get into medicine? Where was your? Tell us about your schooling, Bill.
Yeah. So I went to a day school in London, and I was quite good at science at school, and in those days things are so different now. I think now, back then it was all about professions. If you're good at science, okay, engineering or medicine. I think now there's so many more options in terms of careers, and much more entrepreneurial activity people are encouraged to get into. But then it was very much engineering, law, medicine, and I like science, but I also like sort of dealing with people, and so medicine seemed the perfect combination the two of basically using your scientific knowledge, but actually interacting with people as well. And, you know, like everyone, I did some placements at Roehampton Hospital, as it was back then, and Charing Cross, and sort of was sold on it. Now, I was the first one in my family to get into it, and I like to think it was my idea, but of course my brother was 2 years older than I was, and he also went into medicine. So in retrospect, I probably copied him.
How can you be the first one to get into it if he's older and he's done it as well?
Yeah, I know. Well, I can't really. But no one else in previous generations were medical at all. Basically,
we didn't need to bring that up.
That's okay. Just for factual correctness.
Just for, I think
yeah.
It's interesting though, Bill. I think you're right, because when I mean, I don't know how old you are, but when, you know, I remember when I was at school and we went to the careers advisor. The careers advisor sort of looked at what you were good at or not, which for me was more than not. But anyway, and then basically said, well, you could be a nurse, work in a bank, hairdresser. You know, it was there was none of this sort of. They were very blanket. And then, like, going into medicine, I think this is what's interesting about how then people choose their careers in medicine, because medicine is a universe. It's not sort of one career, is it?
Well, we could talk a little bit about that, about how in medicine, why people go into different specialities. So I've noticed nearly every ophthalmologist wears glasses.
Is that just not an age thing, Adrian?
No, they all wear glasses, and none of them have laser eye surgery.
Ooh, maybe
So
apart
check that
from
one
that
out.
chat.
You're not going to make a comment about psychiatrists as well, are you?
I was thinking about it, but I thought no. So when I was at school, I had my aptitude tested, and it said I should be an astronaut. That was the only job for me, apparently.
Wow.
I think that was more they wanted you out of there.
They wanted me gone far away, I think.
Yeah.
So Bill, so Bill, where did you go to university?
So I read my undergraduate medicine at Cambridge. And then I did my clinical course at Oxford. So both places that I went to, not just so that I could go to both. Cambridge had only a proportion of Cambridge undergrads went on to do clinical medicine at Cambridge, and actually the majority of the rest just went towards Oxford, because that's where they had capacity, and it worked well.
Yeah. And who do you support in the boat race?
Cambridge. Yeah, I think that was. I loved my undergraduate time there. Really, it was fantastic, and I think I'm fully behind Cambridge in all sporting and other activities.
Okay, here's a question for you, Al. Which end of the punt do they stand on in Oxford, and which side in Cambridge? The big end or the small end? When they're punting?
I've got no idea.
She doesn't know. Bill.
No, they don't stand. I don't know. I'm going to make myself look
Adrian,
stupid.
tell us.
I know it's different, but I've forgotten which one it is. Which one is it, Bill?
Wow. Oh, gosh. You're testing me. I don't know.
Because on a punt, there's a narrow bit on one end and a big end on the other end. And Oxford and Cambridge, they do it the other way round, I believe.
Yeah, okay. That is truly a new fact for me today, so thank you.
We're looking at that.
Yeah.
Now, I've spotted zoology here.
Yes,
Talk to us about that.
Yeah, so as part of, so in Cambridge, you, rather than reading medicine, you do actually natural sciences, and you spend the first 2 years just doing medical subjects, and the third year you can choose to do whatever you want within natural sciences to get your BSc or BA, as it's called. So I chose zoology. I've always been interested in the wilderness and outdoors. And in my gap year, in fact, I spent time as a park ranger in Paraguay. So I've always had an interest, and it was just a great opportunity to explore zoology. So I spent a year learning about mechanisms, behavior in animals, all sorts of stuff. And as I mentioned previously to Adrian, it culminated in me going to South Africa for 3 months at the end of the year and tracking aardvarks at night to see what they were foraging on, which species of termites, which was completely fun and random.
How do you track aardvarks at night?
Yeah, so they were radio collared. I have to say, it was actually one of the most terrifying things I've done, because they were radio collared. So we had a transmitter to pick up the signal. But basically, you have to park the car on a track and then start walking towards where the aardvarks. Now, this was in a game reserve, so you could come across anything. Of course, there weren't lions or anything like that, but there were buffalo, and you actually had a separate transmitter for other species to make sure you weren't getting too close. But you're following them at night using the moon to sort of navigate across the savannah. I mean, it was quite terrifying actually, but it was fun.
How do you catch the aardvark in the first place? Put the collar on.
Good question. I have no idea. I wasn't involved in that part of the project. We did other things though. We were also, they used to tranquilize, we were also looking at sort of testosterone levels in rutting springboks. So they were tranquilizing springbok, and then we were taking blood samples from them. That's the first sort of blood sample I'd taken was from a springbok. Rather than
How did you tranquilize a springbok?
With a dart. I mean, I didn't do it. The rangers did it. They basically shot a dart into the shoulder. And they would be out for about 5 or 10 minutes. And then you had to rush and then take the blood sample. And then, there are often sort of jackals and things a bit interested. So you had to wait till they were recovered enough and then just keep an eye on them until they could get away safely.
Wow. That's interesting, isn't it?
Yeah, a little bit different. So then you finished, and when you went into medicine, did you have a view or a feeling of what type of speciality you would then go into?
I genuinely did not at all. I was very open-minded. At one stage I was interested in cardiology, but I think by the end of medicine, I knew that I wanted to do surgery because I like the sort of short-term, immediate rewards you get from surgery. In other words, you can make a difference straight away. And I think that was important to me. I liked seeing the difference straight that you can make. And that's very different from medicine and other parts.
So one thing about surgery, I think, Al, is you generally, in most cases, do an operation which makes a difference and people get better. Whereas obviously, because I know you were a urology sister, weren't you? The youngest urology sister in London, Bill.
Again, my claim to fame.
Yeah.
And I liked urology partly because exactly that. Patients came in, they had their surgery, they got better, they went home. You didn't get bored of them. It was
no.
But cardiology is interesting. But you can you'll see patients in outpatient as in clinic and maybe change their medication slightly, and then 6 months later see that their blood pressures come down 5 or 10 degrees. It's a very different discipline, and there is some satisfaction in that, obviously, and an intellectual sort of level as well. But no, I like the quick reward you get in surgery.
Bill, just tell us a little bit about what you think are the characteristics for someone who decides to be a plastic surgeon. What made you be a plastic surgeon?
I think there are, I'll tell you about my individual sort of how I fell into it, because there are, I think, set characteristics that define a plastic surgeon. But for me, I found my way into plastics via hand surgery, which I think is not uncommon. I was initially interested in orthopedics, but really I found it really boring, apart from the hand surgery. And at that level, you get a feel for the anatomy and the intricacy of all the soft tissue work. And that's what drew me into plastics. But of course, that was my entry. But what sort of convinced me that I liked it is just the complete variety and spectrum of procedures, of conditions that you can treat. I think it's fascinating, and it's an evolving specialty that a relatively new one, but you can make such. It's come on so far, and there's so much potential for new treatments. So I just really enjoyed getting into it that way. There are, so I mean, that's how I fell into it myself.
Yeah, so I was a hand surgeon as well, believe it or not, Bill.
Okay.
And
Yeah, I didn't know that.
we could talk all sorts of things, hand surgery, couldn't we? Dupotrons and carpal tunnels and all the different carpal arthroscopies and things we used to do.
And how the long winter nights would fly by. Let's move on. Right.
I mean, to be honest, now I find hand surgery extremely dry, and I'm at the very completely different end of the body in the head and neck stuff, which I enjoy much more.
Do you ever do any hand surgery anymore, Bill? No.
None whatsoever, except that I cover the on-calls, obviously, at Guy's and St Thomas's. So occasionally I'll have to put a finger back on that's been amputated, or get involved in hand trauma. So yes, I do some, but minimal.
I think it's funny with surgeons, or anyone in medicine actually, when you think about it. I remember years ago being on a ward round, and we had this amazing sort of urology oncology chap, and I remember him coming around, and he said to this patient, I was doing the ward round, and he said, "No, it's fine. Yep, we're just going to whip your bladder out tomorrow, and it'll all be fine." And then he marched off and kind of left the patient that we had to pick up off the floor. And it's a little bit like you, Bill, saying, I mean, if I have to just pop a finger back on, then I do that. It's like saying you're going to Marks and Spencer's to buy the dinner.
That is true.
This is not something very right. Some of our audience will be thinking, I think I'm quite clever. I could probably do one thing, but just popping a finger back on is kind of something different. Now, but your plastic surgery, we were chatting earlier, so there's lots of bits to it, isn't there? Do you say you do some oncology work as well, or have I?
Absolutely, yeah. So my NHS practice, my practice is split between NHS and private work. My NHS practice is exclusively head and neck cancer reconstruction and correction of or treatment for patients with facial palsy, so who have a complete flaccid weakness on one side of their face.
So could we just delve into that? So when you become a plastic surgeon, so obviously, Bill covers lots of different areas. So within plastic surgery, it's one of the broadest specialities. So you could be a burn surgeon, cleft lip and palate, hyperspadias, breast reconstruction, hand surgeon, and head and neck surgeon. So can you just tell us a little bit about what it means to be a head and neck plastic surgeon?
Yeah, absolutely. So in plastics, we are supporting other disciplines, particularly in oncology, in head and neck cancer. So they would remove a tumor from the head and neck region. And typically those are from the jaw, maybe from the face, the scalp, the tongue, or even the larynx. So there are resecting surgeons, usually ENT or maxfax, that will remove the tumor, and the plastic surgeons put things back together. And that's what head and neck reconstruction is. And it's hugely diverse. So, if we're putting a jaw back together, we'll take a bone from the leg, the fibula, which is the smaller bone of the two on the lower leg, and reshape it into a jaw, and then transplant it into to create the new jaw. So it's a hugely varied discipline.
Yeah. Can I just say that it's a bit more complicated than just getting a bit of bone and reshaping it, because you have to vascularize it, don't you, Bill?
You do, yeah. So I don't know how much technical jargon we could go to here, but you're absolutely right. If we just took the bone, it would not survive, and that's why I say it's like a transplant. It's like a kidney transplant. You put it to someone else and attach it to blood vessels. It's the same with the bone. So the bone comes with blood vessels going into it, an artery and a vein, and we attach them to blood vessels in the neck. So an artery which brings blood into the bone, and the vein takes the blood away. And we do that under a microscope. So these vessels are 1 or 2 millimeters in diameter. They're tiny. So they have to be stitched together, hand sewn under a microscope. And they will only survive if you can get the blood flowing in and out.
And how long does an operation like that take, Bill?
A long time, 12 hours, 10 to 12 hours, typically for a big operation like that. Most of our head and neck cancer cases we do 1 case each day, to give you an idea.
Wow. So, Al, they're big operations. I used to do them in Oxford. I used to be involved you know, if you're taking out an esophagus or a larynx, you have to, you know, make a tube, don't you, Bill?
Yes, yeah, absolutely.
Reconstruct the larynx. Patients often can't talk. They need tracheostomies. You sometimes need to take all the lymph nodes away from the neck, which is a neck dissection, don't you, Bill?
Yeah, which is
so
part of the cancer
these are big operations.
And when
So-
someone's had the cancer, the tumour sort of taken away and resected, what's your time frame between that being healed and then you do the reconstructive work?
Oh, we do it all in the same operation.
Oh, I see.
So they have the tumor taken away and put back together all in one operation.
So what the ENT surgeons, normally ENT surgeons out,
Yes.
they would do the resections. They take the tumor out. So you can imagine if it's a tongue tumor, a big tongue, you know, there's a lot of things around the base of the tongue. They take it away, and then they go off, and then the plastic surgeons come in and put it all back together. That's the way it works, isn't it, Bill?
Yeah.
And
Yeah,
the plastic surgeon, so you may, but when they're taking it out, sometimes you're working on the leg, preparing the.
Absolutely.
Oh, I see.
Yeah. And so that 12 hours, we may not be operating the whole time either. In fact, we'll often be waiting perhaps for them to finish taking the tumor out. We may be able to do some of our bit while they're still taking the tumor out. They're long cases, but it's enjoyable because I like working with other teams. I think that's another key function or necessity for plastic surgeons. We work with other specialties. That's key. And I really enjoy that, the team working. It's really enjoyable.
Yeah. Can I just say, Bill, so head and neck cancer associated with smoking, alcohol, all those bad things.
Yes.
Do you think it's going up? We've seen more cases?
So we are, interestingly enough, those traditional risk factors, smoking and drinking, are probably fairly static in terms of new cancers. But what we're seeing a lot of HPV, human papilloma virus, like warts, related illnesses. So in other words, patients particularly who have tumors of the tonsils or the back of the mouth, we're seeing a huge rise in the cancers related to HPV, which is a type of virus. And that's over the last 10 to 15 years, have perhaps doubled or tripled even for those specific types of tumors.
So another troublesome virus. But is there any way?
And another one where a vaccine could be really useful.
Mm-hmm. Is there any way of reducing your risk of it, Bill?
So there is a lot of speculation. And some of it, obviously, some HPV viruses are sexually transmitted. So there may be a link with sexual activity. But a vaccine in children or teenagers, I think is probably the way forward in terms of reducing exposure and also the risk of developing these tumors later.
I think there is a vaccine, isn't there? Because HPV, the virus for the HPV is the one that Michael Douglas had, isn't it?
Yeah. Yes. Yeah.
Yeah. And
you are right. I think it's just not widely.
It's not available. It's not available on the NHS. But interestingly, so I've got a teenage son, and we said to my son, right, because a friend of mine's husband had it and had developed sort of tumours. So we said to my son, right, okay, we've decided we're going to get you the HPV vaccine because you're a teenager now and everything. But you know, it's not cheap because I think it's about £200 a shot, and they have to have a series of shots. So it's not cheap, and you can only get it done privately. So we said to him, you know, that's really the cost of an iPad getting you vaccinated for HPV, but you can't go kissing or doing anything until you've had it. So which would you prefer, an iPad or the HPV vaccine? I've never seen vaccine come out of someone's mouth so quick in all of his life. So.
Really?
Yeah. But he is 16. So we got him vaccinated privately. But there's real controversy about it. Some people say that you shouldn't. It's like any vaccine. There's controversy about it, but it is available, but it is expensive.
Yeah,
you're right.
Okay.
You are right. It is a big public health issue, and debates about how available it should be are ongoing.
Okay, so that's what you do in your main life. We should probably touch a little bit on facial palsy as well, Bill, your other main interest.
Yeah,
so
sure.
Could you just tell us about, Bell's palsy, and the reconstructive techniques?
Great, absolutely. So facial palsy is a condition where part of the face, usually half the face, just drops suddenly. So patients are not able to close their eye, the corner of the mouth drops, they can't smile on one side. It's a very stigmatized look, but also they really are hugely disabled by not being, by the loss of social function, but not being able to eat food properly, etc. There are lots of causes, but the commonest is what's called Bell's palsy. And a lot of people have heard of Bell's palsy. It's actually, ironically, it's a diagnosis that you get to by excluding others. It's a diagnosis of unknown cause, but probably related to a virus that patients get, and it causes swelling of the facial nerve and therefore stops it working temporarily. So that's by far the most common cause. And actually the majority of patients get better completely, but about a third don't and may need further treatment. But obviously at Guy's, we get patients who've had, head and neck cancer or brain tumors and have facial palsy. So we have a wide variety of patients. It's an amazing discipline because it is so varied. There's so many different techniques. At the very sort of sharp end, we're trying to put the nerves back together, or even take muscle transplants from the leg to make people smile again, just like the bone, having to attach it to blood vessels, giving new muscles to the face. But also it crosses into aesthetic. We do a lot of procedures to improve symmetry, brow lifts, face lifts, fat grafting. It sort of crosses both reconstructive and aesthetic disciplines. And it provides a really nice balance with the head and neck work, which is really intense, and the facial palsy, which is also intense, but I think it's a nice balance.
It's quietly intense. Just for a recap for people out there,
Yeah.
the facial nerve is what number facial nerve? There are 12 cranial nerves. So basically cranial nerve is a nerve which comes directly from the brain. Okay. And there are 12 of them, which all plastic surgeons, all medical people know, don't they? The facial nerve is which one, Bill?
It's number 7. Seven of 12.
So 7.
And so one comes out at the top and sort of 12 comes out here, just sort of if you wanted to visualize where the nerves come.
Yeah. So the facial nerve is the power nerve to the face, to the muscles. It comes through the skull, and when it gets in in Bell's palsy, it gets inflamed. So it goes through a small hole, it swells in the hole, and that's why it gets damaged. And it splits into 5 branches. So for non-surgical people, those 5 branches, going different areas. And the trigeminal nerve is number 5, which is the sensation to the face, and that's the one, the supraorbital, supratrochlear, mental. That's sensation. Facial is motor, trigeminal, sensation. Is that right, Bill?
Yes. Yeah, absolutely. So the 5 branches, as you say, are eyebrow raising, closing eyes, smiling, lower lip movements, and neck movement as well. It's the platysma, which we know a lot about in facial aesthetics.
And Bill, tell us the mnemonic for remembering them.
You probably know. You know what? This
Clearly, that's why
book.
he's asking. Yeah.
This must be in your book. You tell us.
I think this is a family show, but there's a mnemonic for remembering the branches. So it's 10 Zulus borrowed my cat. Yeah, is the thing. So 10 is temporal. 10 Zulus zygomatic to the cheek, borrowed buccal to the cheek, my mandibular. That's one we're always watching out for underneath the jawline, and cervical goes to the platysma.
Platysma, yeah.
Yeah, that wasn't actually the mnemonic, was it, Bill? but it gives you 10 Zulus borrowed my cat. Yep.
I like that. We'll go with that. When did you start, Bill, then moving into private practice, and what makes you go from doing what you're doing to into private practice?
Most people, I think, go very early on in their consultant career who are going to be interested in private practice. I probably was maybe 6 months after starting as a consultant at Guy's and St Thomas's. What makes you?
Three kids in a house in London.
Yeah, I mean, to state the obvious, that is a major driving force, and a black Labrador now. So yes, that is a big driving force. But actually, again, talking about balance in your practice, it provides a really enjoyable balance. And I enjoy a lot of the aesthetic work and the aesthetic procedures. I find them very rewarding. It's a different sort of reward. Patients again, find it very satisfying, and you can make a huge difference to their quality of life in a way that's different from how, operating on someone with a head and neck cancer, but in a very satisfying way as well. The surgery is also very different in that it requires a lot of very careful planning and execution. There's very little room for error. And with the whole aesthetic side of things, there's an extra dimension in terms of what you're aiming for and what you need to consider when you're trying to perform an aesthetic procedure. In terms of getting the result, it's not just mechanical, but it's a really important appreciation, form, and beauty.
Yeah, Bill, could we just I know you do a lot of facelift surgery. Yeah.
Yeah.
So can you just explain the different types of facelift, like facelifts for beginners? What are the different types of facelifts?
And also, when would you start? I'm saying this because I don't have a big nose, but I might be interested in facelift. And also, because when would you start recommending?
Yeah.
Because we see sort of changes. Where I come from with this is, I think you get to a point, fillers and Botox amazing, but you get to a point where you can't lift the jowl with however much you put in. So what are your options there? Because I often have clients who need something lower, but they're okay up here still.
Yes. Okay. So I think when you're looking at the face, so first of all, different types of facelift. Really, when we talk about facelift, we talk about a lower facelift, and it's about lifting the jowls in particular. I think of the facelifts I describe are either what's called a short scar or mini facelift, where the incision is all at the front of the ear, then a full lower facelift where the scar goes behind the ear as well, and then a face and neck lift where, in addition to the scar in front and behind, there's a small incision underneath here as well, so you can access the neck. There are hundreds of different types of facelifts in terms of what you do underneath the skin, but thinking about the incision is a good way to start, at least. That patient you described, Alison, is with a bit of jowling that Botox or fillers in particular just not really correcting to the extent they want. I see a lot of those patients. I would consider a mini facelift if they had a nice neck contour or there wasn't a very obtuse neck. And it's a great option for just tightening the jowls. And so that's where
would Alison be suitable for that procedure?
No, I'm serious about this. Now, this is very taking. Because quick consultation, sorry podcast, but because I have a short lower third, so.
What do you mean you have it? Explain your short lower third.
Alison. Oh, okay. So when we look at someone's face, we sort of divide it into thirds, and all thirds should be proportionate. But
so look straight at us.
I'm slightly class 2. I do have filler in here because I have a short chin. But what's happening is I don't want any more volume. I don't want any volume in my face because I don't particularly need it. But I am.
Explain, is that because the distance between the base of your nose and your chin is short? Is that what you're saying?
Yeah. So and because I'm slightly class 2, I don't have a particularly strong jawline.
So what's class 2?
So if we think of the dental classes, so class 3 is someone like Keira Knightley with a very big lower jaw.
Yeah.
And what we always know with those patients is they will age well from a jawline, but they'll flatten in the middle.
Because they have support. Absolutely.
Yeah, because they have the support. You've then got class 2, which is a very British jawline, which is the lower jaw, the chin is slightly retrognathic, so it's slightly back. So there isn't much support in it and there isn't much tissue in it. And basically what happens is, but we tend to age well in the mid face, but then our face falls off the bottom of our face, essentially. So that's class 2 in my view. And then you've got class 1, which is kind of your good alignment. So
obviously Bill and me are class, we're class 1. You are class, is that right, Al?
I don't know. It depends on you. I can't see very well, but yes, we'll go with that. We'll go that you two are great. We'll go to that you two are great, and it's just me that's got issues. So, so it is, and I think so. This is off at random. So I'm 47, and I just know now I don't want any more volume, but I don't like this jowling.
Yeah, I think in that situation, I would be definitely considering a short scar facelift. You know, you have to assess someone whether they get away a short scar. Yeah.
The only thing is, Al, I don't think you're ready yet. It's not bad enough yet. Would you agree?
I'm talking generally. I'm not trying to make any inference about you, but someone who's in that position.
I booked a consultation for after lockdown with someone because I've just seen this jowling develop. Well, not just, it's been creeping up.
Yeah, but honestly, it's probably a bit overkill for you now, in my opinion.
Well, I
have quite a few patients who want to have. I think one of the advantages of a facelift technique is the longevity it gives you. Not that it makes you 10 years younger, but that it resists aging. It resists sort of future aging because just the way you can suspend the deep tissues. So I have a reasonable number of patients who come to me because they want to have the surgery before it's going to be a dramatic change, because what they don't want is to wait until they get it done and then people will be saying, oh wow, she looks completely different. They want it relatively early, and then it will provide a lasting sort of solution over however long, 5 to 10 years.
Yeah.
But I agree,
one thing I used to say when I did facelifts is basically, gravity affects the face. It goes down. Yeah. Every year it goes down a bit more. It doesn't go down gradually either. It goes down in jumps. A facelift basically just puts the tissue back where it was 8 to 10 years ago, Bill, would you say?
Yeah.
Yeah. So it just undoes 8 to 10 years of gravity changes on your face.
Do that again, Adrian. That looked quite on you.
Well,
I can't see Adrian, you're totally right. I'm interested.
Well, I've got to be honest with you, close members of my family, very close members, have had facelifts. And okay, I'll tell you, my dad's had a facelift, right? And on his 80th birthday, he looks young. When I went in for a meal, he had a big meal, and the guy in the restaurant knows him, the maitre d' knew him, and I walked in, and he goes, I presume you're David Richards' brother. Yeah. And my dad is 80, but he looks younger. And, it's just a natural, it will make you look younger, just because it reverses the gravity. And it's ideal, Bill, on someone who's slim. Who is the ideal person for a facelift, Bill?
Yeah, as you say, I think with a slim patient who has a lot of facial ptosis in this region. Interestingly enough, I think a strong jawline also helps to give a long result. It's interesting because you're saying they're going to age well and less likely to need it, but it will also help support the facelift.
So could Alison and I book in together?
Can you do 2 for the price of 1?
Yeah, you can do me.
You just need some filler, Adrian. Right, sorry. Now,
Adrian, you don't need anything. I would say the one thing we haven't mentioned is in the younger patients, and because we've been talking about jaw lines, there is a case in younger patients, 20s or 30s, of what I would call a mini neck lift or short scar neck lift. And that's a patient with a really obtuse neck and fullness. And they may have prominent submandibular glands or just deep-seated fat that just is going to be without the sort of strong jaw to give them a nice contour. And actually a combination of putting a little chin implant and then removing some of that excess through a small incision is a good way of restoring neck contour. That's not about jowls, that's about neck contour.
Yeah, so one of the problems is that the cervical, this angle, should be quite sharp. So some people just genetically don't have that angle. They don't have a sharp angle here, and you can get a fatty neck can be submandibular glands, can be fatty tissue, can't it? So you can really restore that angle. It's very makes you much more youthful.
But I think there are some younger patients who particularly suffer with that, and it's not necessarily through aging. It's more of a genetic issue, just with how the glands drop into the neck and how they have certain deep-seated fat. Those are the ideal patients because you're not removing skin. They don't need skin removed. They're young. And actually, when you restore the contour, the skin is redraped over a greater surface area, because if it comes straight down here, you need less skin than if it's redraped over the whole contour of the neck. And so, in fact, you don't need to take out neck skin.
And the way that we do that non-surgically is we will do cool sculpt if they're suitable. So we'll do cool sculpt, and then we'll do chin augmentation to give them a better definition. So we kind of do it two ways.
No, I think that's exactly right. I think the chin retrusion is a big part of the issue, and augmenting that will help for sure. And fillers or whatever it will work well.
Here's a controversial thing. Okay, so basically, facelift surgery is not going up. The number of people having facelifts is very static. It's not going up. The amount of non-surgical treatments is going up a lot. Okay, now. The reason I think is non-surgical treatments are much better marketed and publicized to the public. Okay, so in the best possible way, there is a place for facial for operations, and there is a place for non-surgical procedures. And at the moment, I think we're non-surgical. There are limitations to non-surgical. We know that. But we need to be realistic about the limitations of non-surgical to redress the balance for the best interest of our patients, in my view.
Yeah, I think that's true. There are limitations. One of the issues, and Alison, actually, it'd be interesting to hear your comment on this, because my own feeling is that perhaps aesthetic practitioners who don't perform surgery perhaps may have be less sure of where the right time, when the patient is appropriate to start considering more surgical treatments. I could be wrong about that, but do you think that's true?
I think so. I think that sometimes, within my clinic, we have modalities to do everything. We can do radiofrequency, cool sculpting, so we've got everything. But there does come a point where you look at a patient and you think, it doesn't matter how much money you keep spending, you're never going to get that lift that you need. But I think maybe there are practitioners out there who don't want to let the patient go. But whenever I tend to refer, what tends to then happen is I tend to refer to people, a little bit like you, who do a bit of both. Because what I want is, so for example, I referred a lady recently, she wanted a neck lift, her jawline wasn't brilliant, and the surgeon came back and said, yes, let's Alison do what she wants to do with the jawline, with some Volux and things like that, just give a bit of support, and then I can consider the surgery. So, but what I always say to patients is, go and have your facelift or whatever it is, because then when you come back and I will look after you still, my results are going to be better. So I think that's
a great way of doing it.
Yeah, and so you just have to work with the right. I think patients, and if I've got a patient in front of me who the reality is, for me to lift and fill and radiofrequency and cool sculpt is going to cost her £10,000, I will say to her straight up, is surgery an option? Because you're going to spend this much with me and you're going to have to maintain it, and you're going to go through a longer process, and the results will be good, but they might not be quite as predictable as potentially surgery.
Yeah.
But it's how you build your practice, and that's why I think our patients stay, because I do send them away and then they come back.
Yeah.
I think that's absolutely right, and that's a great model for working together, isn't it? I think that that gets the best for the patients. I also wonder whether facelifts are just less in vogue. It could be an issue about marketing, but they get a lot of bad press, don't they? About
they get a lot of bad press, Bill. Right, but basically,
people, you hear about the worst facelifts, not the
Yes.
best. You never get,
Yes.
you never see on any celeb magazines, oh, look, so-and-so looks fantastic, they must have had a, it's always, oh, she's changed so dramatically, and it's almost a negative thing, isn't it? It's like they've had...
Yeah, Bill, so non-surgical's definitely got better, okay? How many of the people in the current eye, sort of 50-year-olds, have had facelift, and would we know?
I don't know, honestly.
I think so. I mean, if you look at people, I'm going out on a limb here, so I may be, but Amanda Holden looks incredible. Whoever is doing her treatment now, she's having surgery. There is no way that she is just aesthetics. She's had something done, and I think the problem is with facelifts is people see it as almost a failing, a giving into it. They see aesthetics as I'm just getting my hair tinted, it's just an extra bit of maintenance. Whereas a facelift is admission of defeat almost. I also think that a lot of the people who are prepared to influence, shout, publicize are the younger generation. Whereas when you get to your 50s and that, you become a bit more private about these things. So I think that's the discrepancy. But when patients say to me, would you have a facelift? I'm like, absolutely, because there will come a point where I'm limited with what I can achieve.
So just another point quickly is people think facelifts are big, horrible operations which take a long time to recover from. So with modern anesthetics, local anesthetics, you don't need, in many cases, you don't need to be put to sleep. And, so you could have a facelift and be back socially in how long, Bill?
2 weeks easily.
Yeah.
I mean, potentially less than that, depending on the nature of it. If we're doing for a short scar facelift, potentially 7 to 10 days. And I use this fibrin glue now to sort of secure the skin down. It reduces bruising really nicely. And so actually at 7 days, they may have to put something around their neck because the bruising often comes into the neck, but they could be out socially facing ready.
Yeah, sorry, Bill, but just say that a facelift is a great treatment for people for the improvement for per time. It is a great option. Yeah. Sorry, Bill.
Fantastic. Yeah, no, I completely agree. You have a lot of control about what you're treating as well, and you make a long-lasting improvement and a change that everyone wants a natural result now. And actually, the modern techniques reflect what people want, which is a natural result, and they want to get back to work quickly. So the modern techniques are perhaps slightly less invasive than they were 15 to 20 years ago, and they deliver results where patients actually just look healthy and really well, not that they look identity. There's no identity changing sort of procedure. So it can have a very positive impact.
I was going to say, I always say to patients, and this is what you're saying, you want to look like you don't need anything doing versus you've had something done.
Yes. Yeah.
So essentially, facelifts are out of vogue, but they really shouldn't be. And non-surgical practitioners, there's been a big swing towards non-surgical. It really, and the basic reason is that facelift surgeons in London, you can only do 200 facelifts a year maximum, really. All the good facelift surgeons are busy. They don't advertise. They don't need to advertise. So there's no advertising for facelifts. So that's why not many people have them, basically.
And I think part of the marketing is actually patient-centered as well. As you said, Alison, earlier, the younger generations are much more au fait with social media. My rhinoplasty patients, who are generally younger, they are so happy for me to put pictures up on Instagram with the results, and even though people can see who they are and they have no issue with that. But my patients who have a facelift don't generally want that picture to be put up. So perhaps there is less promotion amongst patients as well of the procedure, because actually it's generally they don't want other people to know they've had it, and that may contribute to it being less fashion.
So Al, will you be having a consultation with Bill?
I will.
Yeah.
I will. And I will. And you can use my pictures. What was I saying? I know we've gone over, but I actually think it's been, I don't think that matters. We can cut out some of it because I think it's been really interesting talking about faceless, non-surgical, surgical, and that kind of thing. Because I do think it's something that we need, that is interesting.
And Al, I think that you're absolutely right, Al. The problem is that if you've only got a hammer, everything's a nail. Yeah.
Yes.
And you know, if you're a non-surgical practitioner, you know, so okay, this is an example. Okay, I'm short-sighted. Yeah, I spend loads of money on contact lenses and glasses. Yeah.
Mm-hmm.
Is it in my optician's interest to refer me for laser eye surgery?
Yeah.
No, it's not. Well, yes, it is, because if you have laser eye surgery, your eyes are going to change. You still need glasses in the future. But no, it's not. Of course, it's not. And I think but that's like anything in this industry, isn't it? If you're really good and really busy, then letting the odd patient go off for a facelift doesn't matter.
Yeah.
And actually, they'll respect you more and appreciate you more than you can continually. It's a bit like acne patients. So when I get a patient in who's got severe acne, I could sell them a course of blue pills, I could put them on tretinoin, I could do everything with them. But I straight up say to them, would you consider Roaccutane? Because if you would, I think you should go and have a consultation. Once you're finished, I'll then manage your scarring.
Yep. And you're going to get better results. So if your patient goes to Bill, has a mini facelift, the skin's all tight, your filler work is going to show through the skin. Because if the skin's all loose, you can't really see what you've been doing. It's difficult.
You'll need smaller volumes. Yeah, that's very true.
One thing, Bill,
I guess actually, obviously, this dynamic between you two works fantastically, and I think that I wish there was more of that sort of combined, joined up thinking between our sort of plastic surgeons and the aesthetics world and aesthetic practitioners. I think that actually mutually we have a lot to benefit.
We do have a lot to benefit, because there's a surgeon who refers to me he does really interesting transgender stuff. So sort of but he'll do his patients male to female, and he's an amazing chap. And then he sends them to me and I soften them with fillers. So I'll soften the face and sort of contour it and things. But this is where, genuinely, going back to your thing about your skiing trip, whatever it is, you need to bring the two disciplines together, but you need to bring the best of the two disciplines together, obviously, because the problem is, like anything, I'm sure there's some surgeons out there that aren't great, and there's a lot of practitioners out there that aren't great. And so you need to get that mutual respect. You need to sort of bring that together. And this is partly why we did the podcast, because it's very rare that you can find a surgeon and a sort of aesthetician, whatever you want to call me. But when I first met Adrian used to refer to me patients prior to facelift, and we used to do radiofrequency treatments on them to prepare them for facelift. So that's other ways that we work together, but that collaboration needs to come together.
100, you're absolutely right. So one thing I was thinking of, Al, this is a question for you. Yeah. Would you like to go and see Bill perform a mini facelift?
Yes. I say that last time I saw when I was a student nurse, I saw they used to have this procedure called like a commando procedure where they used to literally peel down the face. I went to see one of those and I collapsed on the theatre floor. So maybe, that would be great if I could come.
You have to sit down, Bill.
I have one or two friends who run sort of aesthetic clinics, and actually they have contacted me saying, can I come? And they're interested in eyelids, actually. I think the anatomy and just seeing the surgery, they want to come and watch surgery. So anyway, it's possible.
But I think, guys, I think we're all on the same page. I mean, we're all from slightly different disciplines, but the more you know about other, about other tools.
Adrian.
I know about the hammer and the nail. The more you know, the more tools you've got, the better. Yeah,
absolutely. And of course, obviously works both ways. I know, my knowledge of what can be achieved with all non-invasive treatments is really infinitesimally small compared with yours, Alison. So it very much works both ways, doesn't it?
Yeah. And Al, do you do many non-surgical rhinoplasties?
I don't do any. I don't do any.
No.
And the reason I don't is because I don't get enough demand. I only do things that, I'm sure this sounds blatantly obvious, I only do things I'm really good at. So years ago, I started to try and do leg veins. I would do them once a month and I was rubbish at them. So I canned it. So I only do stuff that I am doing day in, day out that I'm good at. So I don't.
Yeah. But I think you're absolutely right. The more we understand and know what everyone else does, it's better for our patients. And I think you're absolutely right. There's, you know, Al, it's better for you to know who to. So sometimes the difficulty is to know who to refer to, isn't it?
Yeah, it is really difficult actually. And so this is what these podcasts are brilliant, because I'm now meeting and sort of, obviously, because Bill, you do a lot of rhinoplasties.
Yes. Yeah, absolutely.
Isn't there high dissatisfaction rates with rhinoplasties? Isn't that's the kind of, I think, why there's been a swing to people trying to do non-surgical ones?
So that is absolutely the reputation of rhinoplasty patients, that they are difficult and that there's a high level of dissatisfaction. That's not my experience. Obviously, I have patients that are not pleased. I think the failed operation, there are operations where you do not, achieve what you wanted to do, and the patient recognizes that's a failed operation that may need a revision. But there are operations where you may effectively achieve what you were hoping to do with the patient, but they're still not happy. They're not happier at all. And you do see those patients in rhinoplasty because they have such a fixation. I actually do proms I've in fact started doing a body dysmorphia questionnaire on my patients in advance. And if there are any strong red flags, then I have a clinic that I refer them to. But that's something I'm trying to introduce. But it's, patient selection is obviously an important part, but it's not my experience that like a significant proportion are very dissatisfied.
Yes. So we've talked about this before. There are trends in noses. So the very retroussé small nose was in fashion. It's not so much in fashion now. So Bill can create a nose, but it's just making sure that is the nose they want.
Yeah. I think that's, I had a lady recently who had a rhinoplasty and I thought it looked amazing. I thought it looked amazing, and she needed so much reassurance, and she had gone back to her surgeon and said, I don't think it's right. And I've known her years, and I just said, I think you're off your rocker, get over it. It's lovely. It's perfect. No one's going to notice. And I think you're right. I think people become fixated and well, I guess in some ways as well, if it's a minor flaw,
it's easier. If you do have a difficult patient, then I'll get them to see a second. Obviously, you got to refer them to a colleague to have an opinion, because actually, it's much easier for you to say you look great. If I say that as a surgeon, what are you talking about? It looks amazing. It's just it just comes across as if you're not interested, you're not listening. I think it's absolutely the wrong approach. So it's easier. You may think that, but it's easier for someone else to get an objective assessment.
And the acronym, the people you want, we were always taught, the people you want to not operate on, Alison, are Simon. Yeah?
Yeah.
That is single, immature, male, over-expectant, and narcissistic. Yeah? So if you got someone, what are the things again, Bill? Single,
Single, male, immature and narcissistic. And that's absolutely true. I do not particularly advertise for male rhinoplasties because they are definitely the most troublesome. I've operated on models who, they may have slight asymmetries or slight differences afterwards, but they're just delighted. But then, I'll have a male rhinoplasty. I actually had a really nice result, but they just want a revision. They're very fixated. And I'll get patients into my clinic who other people have operated on. And I'll say, they have done an amazing job. I couldn't achieve this. But anyway, they are patients to watch out for sure.
A quote I find quite useful, which my nurse uses all the time. She says, unfortunately, we're not made of graph paper. Yeah. And I think that, the body heals differently. It's difficult to exactly predict things. And I think You know, when you
Or
need
the
to
other
communicate
one
that.
that they say is, these are hands, not wands.
Yeah.
You know, when people
It-
want a miracle, it's kind of like, you know, and I guess it is different being, I think it is different being female as well when I'm talking to patients sometimes, because when they're when they're saying about something that they don't like, I can say to them, listen, I've got that too. If it could be fixed, it would be fixed. It can't. Let's move on and think about something else. You know, I think it does help.
Brilliant. So guys, I think we've sort of run over a little bit, Al, and Bill, because I think basically because it's been such an interesting conversation.
I've really enjoyed it. I hope it was what you were expecting.
I think it's brilliant. And I tell you what,
enjoyed
because I tell you what's been really nice about it is we've had a really healthy debate about facelifts and about the differences between aesthetic, between surgical and non-surgical. And I think that should be the focus of this podcast. We could title it something like Facing the Facelift or something. We'll bring it in, something like that, and go that way.
Brilliant. So guys, anything to add before we end? Alison, Bill?
Bill, when are you starting consultations?
Who knows? Hopefully soon.
She'll be camping out at the bottom of the Shard, Bill, waiting for you. She'll be there in her sleeping bag when you turn up.
I'll bring my MPP. Yeah.
Well, no, I mean, it's great because we hadn't met before, and I've had a chance to see all your amazing clinics in South London. So it would be great to be able to send patients.
Yeah, I'm
here as
coming.
well.
How much do you charge for a short scar?
About, with just a short scar, sort of £8,000 to £10,000, something like that.
But do you sometimes do fat transfer as well, Bill?
Yes, I do. I usually do fat transfer. We didn't talk about that at all. I do a lot of fat transfers in the face with facelifts, and I think it gives a really nice, refines the result.
Because the three things in facial aging are gravity changes, volume changes, and skin changes. If you're doing a facelift, essentially it tightens up and it's gravity. But so Al, you might be using a few mils of filler, but Bill's got much more fat. How much fat would you typically be injecting, Bill?
In a typical facelift, I'll put 12 to 15 cc of fat on each side of the face, up to 20.
And where are you placing it, Bill?
So where I do is the geniomandibular groove here, because even if you do a facelift, sometimes there's a little dip here, so I want to get a nice angle of the jaw. I usually put a mil on the upper lip and the lower lip, and then along the nasolabial fold, and then I put it in the mid cheek to sit on the zygoma to give a bit of volume here, and then on the orbital rim, I go right on the orbital rim to just lift, I guess like you do for fillers, and then on the eyebrow as well, 1 or 2 mils to just lift give it the sense of lifting the eyebrows as well. And I'll put 6 or 7 mils in the cheek.
I'm not sure I need fat transfer, but I've got plenty to share, so I'll give mine to Adrian. I think he needs the fat transfer.
I think I probably do. Yeah, I definitely do.
After lockdown, I've got some to share.
Yeah. Right. Well, guys, thank you very much. Anything else anyone would like to add before we head off into the sunset?
No, but what we can do is in a time when we're back or something like that, we can do another one of these and we can talk about something else.
Mm. And Bill said he was going to invite us all to the restaurant at the top of the Shard.
Which was very kind.
Yeah. Thank you very much for that, Bill.
Okay, yeah.
Well, great. Well, guys, thank you very much.
Enjoy the rest of your day.
Thank you. Yeah. Take care.
No, I haven't gone because of that. I didn't think I was escaping my duties just by getting a blank screen, but it's just my battery's about to run out, so the timing's good anyway.
Perfect.
Okay, guys, thank you very much.
Have a great day and a great weekend.
Take care. Bye.